Hey, wonderful. Thank you so much for joining us. Thank you for the introduction, Jamie. As she said, my name is Margaret Wiesendanger, and I practice medicine and teach here at the Mount Sinai Hospital. And I'm very pleased to just have a little conversation with you. So, as Jamie said, I'm going to first speak, and then it's going to be open forum. So I have a few slides, so I'll talk for about 20 minutes or so. And then I'm happy to entertain any questions you may have. So I'm going to go ahead and share my screen. I'm going to put it in presenter mode. Oh, dokie, and I'm going to change it. All right, so hopefully you're seeing just the one slide. And today we're going to speak about the main types of inflammatory arthritis, which is rheumatoid arthritis, psoriatic, and axial spondyloarthritis. And as you'll see, they share some similarities, but they're also very different. So this is the overview. First, I'm going to talk to you a little bit about how these conditions are diagnosed and also staging, which is sort of a way to assess severity or where we are with the condition. Then I'll talk briefly about the main medical ways that we handle these conditions because they're chronic and they do require some tweaking of the medicines to achieve optimal results. But this came up in the questionnaire. I'd like to talk about what individual patients could do to improve their life and their outcome. And finally, end with some resources. Um, oh, I see Kedia is joining us. Hello. Uh, and like I said, we'll be plenty of time for questions afterwards. So let's start with the most common type of inflammatory arthritis, which is rheumatoid arthritis. This one, it's 1% of Americans, so it is the most common autoimmune condition. And it can be missed early on, or it may not be easy to pick it up. And the reason why it's so important to try to diagnose it early is because if it's not recognized early and allowed to sort of continue and produce inflammation, it can result in deformities of the joints and make it more difficult to use one's hands and feet, etc. So this is a photograph of a patient I saw when I first met her. She had very early rheumatoid arthritis. As you can see, there are no visible signs. And that's fortunate, but there was still a possibility to diagnose early, and I'll tell you in a moment what that looks like. And then I have some pictures from the archives which show what can happen over time. There can be some fusion or flexion deformities of some of the joints, or in this case, the ligaments have, are no longer functioning to hold the bones in a straight line. So now you have unopposed action of the tendons on this joint, on these digits, and it's sort of pulling everything to the side. So, so this is, now I'm going to tell you a little more about the updated classification. This is a way to describe rheumatoid arthritis and try to get some specificity. So here's the thing. All of these criteria, I'm only going to show you two sets of criteria today. They weren't designed to really diagnose people in the clinic, but they're classification criteria that's different from diagnostic. Because the point was at the time to try to understand better what these conditions were so we could study them. So these criteria are really, strictly speaking, they're for research purposes. However, given that, it's still possible to use these in the office setting. And I'm showing them to you so that you can see what the classical rheumatoid arthritis would look like. And it's typically small joints rather than large. So I'm showing you on the right here which joints are large. It's the shoulders and the elbows, the hips and the knees, and which ones are considered small, which would be wrist, and then the knuckle joints here, or ankle, and then the toe joints. So if one has many joints involved, tender or swollen, then you get 5 points right off the bat, and you only need 6 to be pretty confident that this is rheumatoid arthritis. If you're dealing with an earlier version of rheumatoid arthritis, there may not be 10 joints or more involved. There could be fewer, but if some of them are small, then you still get 2 points here. And if you only have one large joint, like one hip or one shoulder, then that would not give you points for rheumatoid arthritis, because that wouldn't be a classic place for the condition to start. More in the past 20 years or so, many blood markers have been found that help identify these conditions. So for rheumatoid arthritis, it's the rheumatoid factor and the so-called cyclic citrullinated peptide antibody, or CCP, which, despite its name, is actually even more helpful than the rheumatoid factor. Rheumatoid factor can be seen positive in other conditions, whereas CCP is fairly specific for just rheumatoid arthritis. So they also get a level of positivity from the lab. So if it's high positive, you get 2 points. Low positive, you get 1. And if about a third of patients with rheumatoid arthritis have neither one of these, so then they wouldn't get points on this classification criteria. You have to use other features to diagnose. And then there are inflammation markers, like the C-reactive protein and the erythrocyte sedimentation rate. If either one is elevated, you get a point for that. And then the symptoms lasting more than 6 weeks also get a point. So the reason for the 6-week sort of cutoff point is because there are viral conditions, virus infections that can mimic rheumatoid arthritis, but they last less than 6 weeks. So if it's been a very short time, you may want to hold off before you're diagnosing this. Okay. So X-rays, yes, they can be very helpful, but early on, they will be normal. And that's a good thing. You know, if you're able, this is where I would like to be capturing my patients before there's been any damage. On the other hand, X-rays can be useful if you're trying to decide, you know, what is the prognosis for this patient? Do they have any evidence that maybe can't be seen from the outside, but there is some inflammation already affecting the bone? So these are called erosions. It's when the inflammation is so strong that it actually damages the bone. It starts to make small holes, and eventually you can lose the cartilage in the wrist, and it becomes harder to distinguish which bones are where. So here, for example, on the left, normal X-ray, and you can clearly see every bone in the wrist is defined, and you can see the cartilage around each bone, so you can see where they are. And there's a nice space in between all the bones. However, later on, there can be damage to the extent that all the bones seem to stick together, and that's because the cartilage has been damaged. Eventually, you can also lose motion at the wrist. So again, X-rays helpful to see, you know, at the beginning, what are we dealing with? And if there are early signs of inflammation already damaging the bones, that would propel you to use a stronger medicine, perhaps, for such a person. Okay, so that's rheumatoid. Let's talk about psoriatic arthritis and axial spondyloarthritis. So these are actually related conditions because there's a family of inflammatory diseases that includes the classic ankylosing spondylitis. Ankylosing means that there's fusion of the vertebra so that you can lose range of motion there. And a number of patients with this condition have a gene variant called HLA-B27. Now, this gene variant is not required to make the diagnosis, but it is more prevalent, more commonly seen in patients with ankylosing spondylitis. Related to ankylosing, but different, is psoriatic arthritis. So this would be an arthritis which is associated with the skin condition psoriasis. It could be a lot of psoriasis or just a little bit, but if you find psoriasis significant and the person has inflammatory arthritis, then you can call it that. You know, that would give you the clue. The thing about psoriatic arthritis that's confusing is that there are many forms of it. Some of them are predominantly affecting the spine and others smaller joints or joints in the limbs, shall we say. I will mention here, we're not going to really discuss them in detail. The two other members of this family of inflammatory arthritis are reactive arthritis, which which follows an infection either of the gastrointestinal tract or genitourinary tract, and is usually self-limited. And then there's enteropathic arthritis, which is a type of arthritis associated with Crohn's disease and ulcerative colitis, two very inflammatory conditions that affect the gut. So I alluded to this already. There are two types of spondyloarthritis in the psoriatic family. You can either have predominantly inflammatory back pain, meaning the pain is associated with significant early morning stiffness. It's not just pain after, say, a hard day's work, but it's already present in the morning, and there's stiffness, meaning a difficulty in moving the back. Some patients have difficulty just getting out of bed. So the stiffness can be very severe, and you can see evidence of this on MRI because, so here is the pelvis, the bony pelvis, and this is a sacroiliac joint here, and this bright signal on MRI is showing that there's extra fluid in the bone marrow. This is inflammation. And then the other type of psoriatic arthritis can be peripheral, meaning there'll be a tender or swollen joint. It could be a knee, it could be an ankle, a wrist, an elbow, not usually symmetric, right? So rheumatoid arthritis can be very symmetric, but psoriatic could be asymmetric. There are different forms of it. There can be inflammation of entire digit. That's because the whole tendon is involved. It can be a finger or a toe. And then also the other piece that can be very involved is exactly where the tendon inserts into bone. This is called the enthesis. So for example, the Achilles tendon, where it comes into the heel bone here, can become very inflamed. So those are the types. So this is the second set of criteria I'm going to show you. These are the Assessment of Spondyloarthritis International Society criteria, and they separate out those patients who have predominantly back pain, spine pain, and those who have predominantly limb arthritis, shall we say. And in order to be able to use these criteria, the person has to have had back pain for more than 3 months. The onset of symptoms should be younger than 45 years of age. They can be diagnosed later on, but they have to have this criteria that they've been having symptoms for a while. They can either have an MRI that shows, or an X-ray that shows sacroiliitis, or not. Either way, you go on to the next bunch of criteria and see if you can find something that helps you figure out what's going on here. So the main conundrum here is always, can we distinguish someone who has inflammatory arthritis, meaning their immune system is hyperactive in some way, versus someone who's having mechanical problems because of tendon damage or cartilage loss, because those would not be inflammatory. So you're recognizing some of the things I already mentioned, which is psoriasis, the HLA-B27 gene, inflammatory bowel disease, enthesitis, that's when the tendon is inflamed, when it inserts into bone, dactylitis, that's when a single digit is swollen. So you can see that this is how rheumatologists try to parse it all out. Okay. So x-rays also can be helpful, but early on, again, the x-ray typically will be normal. So here's an x-ray of the pelvis. You have your hip joints here. And then here is the spine coming down. And then this triangular bone right here is the sacrum. So we're looking at the sacro, right? So this is the sacrum, and these are the iliac bones of the pelvis. This joint here is the sacroiliac joint. This is the left, this is the right. And you can typically follow it all the way. So you can trace it. That's just normal. Whereas if the person has had ongoing arthritis and it's advancing, then you start to see that extra calcium is deposited on either side of the joint. This is called subchondral sclerosis. This is a moderate case. And then eventually over time, what can happen is the joints become totally fused. So the cartilage is gone and now the bone is fused. You can't even see where the joint is anymore. And this can lead to difficulty with walking and bending. Okay, so that's X-ray. It's excellent for showing how advanced the problem is, but it doesn't show inflammation very precisely, whereas MRI does or can. So that's that same MRI I showed you before. You can see these are normal sacroiliac joints on either side, but this one on the left has this bright signal, which is the inflammatory bone marrow edema. Okay. All right. So much for that's a description of how these conditions are identified and diagnosed. Let's talk briefly about how they're treated. So for rheumatoid arthritis, there are many options. We always start out with oral medicines. They're called disease-modifying anti-rheumatic drugs, or DMARDs, because they do have the ability to stop the process or slow it down. You can also use non-steroidal anti-inflammatory drugs, NSAIDs like ibuprofen, but those tend to be more for pain relief, and they don't really prevent the condition from continuing. So we use medicines like methotrexate, hydroxychloroquine, and sulfasalazine. When combined, it's called triple therapy, and this has been shown to be highly effective in patients who prefer not to use injectable medicines or can't tolerate them for any reason. And then there's a fourth compadre here. Leflunomide is also very useful for rheumatoid arthritis. And if those medicines don't work, then there's something called a biologic therapy. So these are injectable medicines that are based on a normal immune molecule called an antibody, which is normally made by B cells. But this technology co-opts I guess usually you make antibodies against viruses and bacteria. That's what they do. So whenever you're vaccinated or encounter an infection, you have memory. Your immune system will remember and it will create antibodies. And this is why we never get measles more than once. It's once and done. So over the last 20 years, what's been discovered is that you can manipulate this type of system and create an antibody in the lab that is able to identify a single molecule that's important in immune activation. And if you use this as a medicine, you can interrupt an unfavorable immune cycle. So many cells here, it's a busy slide, but I just want to show you that there are many cells that are potentially involved in rheumatoid arthritis and psoriatic arthritis. This is specifically showing rheumatoid. So you have T cell over here, antigen presenting cell, that's a cell that talks to T cells, macrophage, another type of white blood cell, different kind of T cell here, B cells, these are the ones that make the antibodies. So they're all kind of activating each other. And if you can interrupt, depending on the patient, this one or more of these pathways will be the important one. And there are differences between patients. So it's not always possible to be sure which one of these pathways is the key and needs to be interrupted by a medicine. But in general, interrupting tumor necrosis factor, because it's sort of in the middle of it all, it's in between all these cells, has been very effective for many patients. If that doesn't work, then there are other options. Rituximab is something that depletes B cells, removes them from the situation. Then you have abatacept, which interrupts the conversation between T cells and antigen-presenting cells over here, and also inhibits macrophages. And then JAK inhibitors, the newest kid on the block here, which works on multiple levels, actually, not just here. So but one size does not fit all, as I mentioned. So for rheumatoid arthritis, any one of these conventional disease-modifying agents can work, but they only work for the skin condition psoriasis, don't really work for the arthritis that's associated with psoriasis. And then they also don't work very well for axial spondyloarthritis, ankylosing spondylitis. And so this is the limitation of this approach. It's really not for everybody. And then if they don't work, or if you're dealing with one of these other two conditions on the right here, you have to go straight to a biologic medicine. And again, it's interesting that, for example, interleukin-17, that's one of the biologics, works very well for psoriatic arthritis and ankylosing spondylitis, but not for rheumatoid arthritis. There's a different biology at play. Similarly for interleukin-23, or another one of these molecules that's important for immune system activation. but luckily the JAK inhibitors like tofacitinib and upadacitinib have multiple effects on the immune system. They're not very selective, actually, so they're able to productively interrupt some of the important pathways in these conditions and help the patient. Of course, there's always side effects associated with these drugs, so it's a conversation. It's a risk-benefit discussion. Okay, so this is a very simplified algorithm of how I like to sort of think about the patients when I see them first, and what's the path, what's the decision points, So first, we have to figure out what we're dealing with. Ask some questions, do a physical examination, and find out if there is a clue to an inflammatory condition. And I always look for psoriasis, even if it's just a little bit. And then if not, none of this is present, well, maybe it's a different kind of condition we're dealing with. But if yes, then we want to know what types of joints are involved. Is the spine involved or not? Is it small joints? Is it large joints? Is it symmetric? Which joints? And then do some blood tests to try to understand the situation better. Does the patient carry the gene HLA-B27? Do they have markers for autoimmune conditions? And then depending if it's more the spine or there's psoriasis, then we're going to go straight to a biologic. But if not, if we're thinking more rheumatoid arthritis, we may be able to do very well with an oral medicine. But if that doesn't work, then we're back to the biologics, and then we sort of go in a sort of escalating pattern depending on the patient's preference, how they're doing, and what information we have from studies of patients with similar conditions. Okay, so much for the medicines. So now let's switch gears. Let's talk about a more holistic view of the whole situation, right? Because when we think about joints, it's not just the bone and the cartilage. We're also talking tendons and muscle, and then there's the whole mind-body connection. So I really like this article. That's why I'm putting the title here. This was a multi-center study coming out of the UK, United States, and Holland, and really saying, we should stop just thinking about numbers and blood tests and x-rays. We should really think about the whole patient, the whole picture. What can we do to improve the situation? So there's been a lot of interest in the diet. And it's not easy to study diet in a condition like inflammatory arthritis. And that's because most studies of diet are based on food recall questionnaires. However, given those limitations, it does seem pretty clear that the Mediterranean diet, meaning, this sort of pescatarian with olive oil and vegetables and fruit, as shown here, this is a mezze platter, and sort of unprocessed food with lean meats. Here I'm showing you some salmon with some avocado on a bed of rice. And this is a chicken breast that's been baked with, or roasted in the oven with, I think these all looks like Brussels sprouts. Okay, I get it, it's not for everyone, but this is sort of what's been found to be most helpful. And I'm hoping for more data on this to be published soon. What has also been shown as less beneficial is red meat, kind of processed foods, high-fat dairy, fried foods, soda, and chips. So, one of the guidelines I like to use is I'm trying to imagine myself shopping with my grandmother, and if she can't tell what I'm buying because it's been so changed from its original form, I probably shouldn't buy it. But that was so this is an interesting idea that I think should be pursued. How can we eat more healthfully? Okay, what about supplements? Well, jury's still out. I mean, a lot of this had been looked at: fish oil, glucosamine, homeopathy. I know it doesn't really look like this when you're shopping for homeopathic medicine, but I thought this was a pretty picture. So maybe it's really hard to tell. This is, I think, an individual decision. We don't really have hard data to support one way or the other. And I would say in general, probably not harmful, but no way to be sure. So I think, again, this is a conversation. What about walking? Well, sure. It turns out it's the best, most underrated exercise. It helps with aerobic conditioning and mood. And these are the recommendations from that article. Half an hour to an hour a day, 3 to 5 days per week. That's kind of what they're advocating for. And my goal as a doctor is to make it possible for patients to do this. You know, I mean, of course, if you're in so much pain, if you have arthritis in your feet, this is not going to happen. So I think the goal is to try to get into a virtuous cycle of medicines help relieve pain sufficiently that one can then undergo these other options, stretching and flowing movements. So these are traditional exercises that come to us. I mean, they're thousands of years old, so there must be something to it. You have Tai Chi here on the left, chair yoga, which I think is a great alternative. And I'm not recommending extreme yoga to anyone who's not already a practitioner. Like, let's just start where we are and go from there. But this can help with flexibility, range of motion, balance, and stress. The recommendation is 10 to 15 minutes per day, 2 days a week. The water can be incredibly helpful. Working out in the water. This is showing aqua size with pool noodles. Recognize that it's not always easy to get to a pool, but this can be incredibly helpful. The water sort of massages the muscles and offers a lot of resistance, but also lifts up the body. So it can be a very beneficial exercise. There's music usually. Recumbent bicycle, no, not this one. This one. I like this concept very much. This way you can just focus on the legs and you don't have to worry about anything else. And I don't recommend necessarily extreme, like spin classes or putting the brakes on the maximum. This is really about, range of motion at first and then strengthening next. But these types of exercises can help with flexibility, range of motion, aerobic conditioning, and strength. Again, 30 minutes to an hour a day, 3 to 5 days a week. That's the ideal. What about resistance training? Sure. Not all of these. I'm not sure crazy about the kettlebell here, but sure. Is it resistance bands, small weights, modified plank exercise is being shown here, and there's some resistance bands this way or that way. So with guidance, I think these can also be great. Helping with aerobic conditioning and strength. The recommendation is 8 to 12 reps, 2 to 3 sets, 2 to 3 times a week. I'm just showing for fun the difference between Linda Hamilton when she was in Terminator and then T2 Judgment Day. She did a lot of resistance training. I'm not saying we should all do this, but it was quite a transformation. All right. And then this is my favorite part, resting and de-stressing. We all need a chance to recover from the day's activities. Sleep quality, quantity, and timing, all of this is important. And if there's any way to take a mindful approach to better sleep quality, and in some cases even consult a sleep medicine doctor if that's an ongoing problem, this can be very important. Hydrotherapy is different from aquasize that I showed you previously. Hydrotherapy is just you in the pool, relaxing in the water and just kind of having that experience. And in terms of stress management, I want to emphasize all the positive things that we can get from our community. We can get a lot of support. The connections, the social connections are super important. Some ways to enhance those connections is to, maybe get involved with a new activity, volunteering, a new hobby, and then staying in touch with old friends and family as well. And then we're encouraging, discuss with our work environment. What can we do to improve our work environment? Can we get a better chair? Can we get a better keyboard if that's something that could help the arthritis? Work with human resources. And I've, had many conversations with patients about, what can we do to improve the work experience? because I think this can be also a source of satisfaction for people. All right, so what are some resources? I'm going to also let Jamie talk about this. But, the Arthritis Foundation is here for you. There's a great website and lots of ways to get connected. Here's a picture from the Walk to Cure Arthritis earlier this year. And, there's a whole community of people out there who have advice and their experiences to share. So in summary, we're recommending that an early diagnosis is best, of course, to try to start the right treatment, the right approach, reduce the inflammation, prevent long-term damage. Holistic approach can certainly yield many benefits for your joints, for your muscles, for your overall well-being, and it's really a partnership between all of us. So thank you so much for your attention today, and I'm happy to entertain any questions if you have them.
Thank you so much. This was a really great presentation and really informative. We really thank you for sharing all of your knowledge and with us this evening and sharing your time. I am now going to open it up to questions. You can either come off mute or you can put them in the chat, and I'm happy to read them for you. And then also just know that I'm Jamie Jordan, and I'm here with the Arthritis Foundation, and we're here to be a support system for all of you. To provide you education seminars like this, or to connect you with others in your community, or help you create a community and be part of the community. And like Dr. Wiesendanger said, we're here, and like best part is to connect with other people. And like that is why the Arthritis Foundation is here. We're here to support you, help you, guide you, and make connections and provide you with education and knowledge and help you live and thrive living your best life with arthritis. So thank you all. If no one has any, does anyone have any questions?
Oh, it's a really nice comment in the chat. Thank you so much, Rachel.
Okay, well, I don't think we have any questions for the rest of the evening, but please feel free to email me. If you do, I will have this recording and I will be sending it out to everyone, so everyone will have a recording of tonight's um, conversation. Sorry, I was reading the chat just to make sure we didn't get a question. Yes, we will be having more seminars like this and more educational seminars throughout the 2025. We are working on them right now to make sure that you are well versed and educated on various topics. This is just one of many to come. So please be on the lookout to stay in touch and engaged with the foundation and come out to our events and meet others like you. So thank you so much. And thank you everyone for joining us this evening.
Oh, and please let us know what other topics you'd love to hear about
Yeah, that would be
specifically. We'll
super,
try
super
to
helpful.
address those. Amazing.
Oh, one question, Rachel.
Oh, go for it. Do you want to unmute or?
Sorry, I couldn't type fast enough. Um, Thank you so much. This was really, really helpful. I really appreciate like you like breaking down like how it's diagnosed and things like that. That was always kind of the missing part for me. Um, so my question, I'm not really sure how to articulate it. So here we go. Um, I am I am doing a combination of methotrexate and infusions, and we just raised my infusion dose. So my question is the goal, and obviously I'll talk to my doctor too, is the goal to be like comfortable or pain free or just like slow the process? I guess what are the expectations when it comes to medication, or is it, or I guess does it depend? And I hope that makes sense.
Oh, it totally does. Thank you for the question. I mean, for sure, we want to stop the progression of the condition. It's not always possible to get to zero pain. So that's the question. What we're trying to understand is for an individual person, is there any damage at all that may preclude us from getting to zero pain? Or is there still ongoing inflammation that could be addressed with either a different medicine or more of the same, but a higher dose or more frequently or something like that? So it's highly, highly personalized, that decision. What can sometimes happen is, I don't know if this doesn't always apply to everybody, but what can sometimes happen is the person tries a medicine that maybe would be more effective, but the side effects are not tolerated of that particular medicine. So then they have to sort of weigh the cost versus benefit of that approach. And so I don't know if I'm not really answering the question, but there are ways to determine if a drug is working, is another thing I want to say. There are ways to measure the amount, to see if you're responding adequately to the medicine, so that's enough. That also comes into play. But yeah, my ideal thing is no pain and full function. Absolutely.
Yeah, that makes a ton of sense. Thank you for saying that. This would be my second round after like the induction period and stuff like that. And I've been noticing like my symptoms slowly coming back. And I guess I didn't realize how much pain I was in until it like quote unquote went away. So I was just curious about your perspective.
That's also true. So now some medicines take a while to kick in. So there's also that to keep in mind. Depends on the half-life of the drug and what's expected. But okay. So yeah, let's see how it goes.
Okay, I don't see any other questions, and I want to thank you, Rachel. That was a really great question. I think that's on a lot of people. I think that's on a lot of people's minds. So thank you. I really appreciate you coming forward and asking that. So thank you everyone for joining us this evening. And we will be we'll be in touch soon with more topics in 2025.
Thank you very much. Thank you.
Thank you.
Amazing. Thank you.
Bye.
Thank you, Jamie. Bye.